Dr. Bishop came to the University of Chicago after 10 years at the National Cancer Institute, and he came to us as a director of the Hematopoietic Stem Cell Transplant Program. Dr. Bishop in his work has emphasized improving communication not only between doctors and patients, but also between healthcare providers involved in patients' care. Today, Dr. Bishop will speak on the topic, Patient Education in Hematopoietic Stem Cell Transplantation. Welcome, Mike Bishop.
Well, thank you very much. I take it everybody can hear me. That's usually never a problem, and I'm microphoned on top of everything else. So I've been very honored to be part of the Bucksbaum Institute, and the mission goes very much in what is in line with what I try to practice on a daily basis, and that's really what the focus of my talk will be today, is in regard to patient education in hematopoietic stem cell transplantation, because I believe that the doctor-physician, the physician-patient relationship is the most important thing, and not only just in relative to what I do, but actually to try and improve outcomes. And so I'd like to share with you a little bit today on the efforts I'm making in our program relative to this. So a lot of people don't know is that the University of Chicago is the birthplace of bone marrow transplantation. And who you're looking at in this picture on the left is Leon Jacobson, who I'm a huge sports fan. And so Leon Jacobson's kind of like the Babe Ruth of bone marrow transplantation. And Leon Jacobson was not only the chairman of medicine, but dean of the University of Chicago. But he was brilliant. I mean, he's brilliant in like 20 different ways. And Dr. Jacobson, shortly after World War II, began a series of experiments because, again, right after World War II, we were very much worried about the effects of radiation. As a matter of fact, tons of research went into radiation injury. And what you're looking at is an experiment that he did, and I didn't show it because it was too soon after lunch, but it was he studied mice, and in mice, the major site of blood production is not the bone marrow, but the spleen. And so what he did in these series of experiments, the doses of radiation that you're looking at this, which is measured in centigrade, was what the survivors of Nagasaki and Hiroshima were exposed to. So they wanted to know, they were thinking about, well, troops are going to be going into battle, what kind of radiation doses and what could do this? And what Dr. Jacobson did, he showed that if you shielded the spleen, that you could actually have survival up to a certain point. Now, this was very, very important. And matter of fact, it was noted by a young physician at Harvard, E. Donald Thomas. And E. Donald Thomas is known as the father of bone marrow transplantation. And what you're looking at is Dr. Thomas receiving the Nobel Prize for medicine. And in his acceptance speech, he said that the work by Jacobson at the University of Chicago was a seminal paper that led him down the pathway to investigate bone marrow transplantation. So Dr. Thomas is the father of bone marrow transplantation, and Dr. Jacobson is the grandfather of bone marrow transplantation. So it was very an honor to be able to come here and actually participate in what I believe is the birthplace of bone marrow transplantation. But today we refer to bone marrow transplantation as hematopoietic stem cell transplantation. And bone marrow transplantation, I'm going to make sure I don't mess this up. I don't my pointer. Okay. So bone marrow transplantation is now referred to as hematopoietic stem cell transplantation because you can think of as hematopoietic stem cells as a seed of bone marrow. And we can get this from a variety of sources. We can take it directly from the bone marrow, we can take it from the peripheral blood, and what people are more familiar with now is actually taking umbilical cord blood in order to do transplants. And the purpose of a hematopoietic stem cell transplant is to administer higher doses of chemotherapy and radiation than we could normally, because the most toxic aspect of radiation and chemotherapy is upon the bone marrow. So it drives down the blood counts. As a matter of fact, to a point that people can't have normal blood production. So it also, and what I really emphasize with my patient, it also provides the patient with a new immune system. And we do hematopoietic stem cells in a variety of ages. Now we start out, there's infants who will undergo a stem cell transplant at 3 months. And we actually now can take patients with hematologic malignancies and do a stem cell transplant up to age of 75. As a matter of fact, that's a tremendous focus of our research here at the University of Chicago is transplantation in the elderly, which is led by my colleague, Andy Arts. And the reason people are interested in this is because it can be curative for a number of diseases which are otherwise fatal, including hematologic malignancies such as leukemia, lymphoma, and multiple myeloma. It can be seen and used to correct immune and enzyme deficiencies in children and hemoglobinopathies, such as people who develop sickle cell disease and aplastic anemia. But it also can be associated with a high degree of life-threatening complications, which comes back to when we heard in the prior talk, is being able to share with the patients because they come with you with the intention of cure, but you have to realize that there is an incredible large amount of risk involved with this procedure. And what you're looking at in this schematic on the right is what happens when somebody goes through a bone marrow transplant. They receive what we refer to as a preparative regimen, which can consist of chemotherapy and radiation. We collect stem cells from a donor, and actually they're infused intravenously, and the stem cells home back to the bone marrow environment. And then subsequently, these patients, you go from a sad face to a happy face, and that they go on and hopefully do live happily ever after. So this brings me to the topic. It's a relatively complex procedure, but again, education, hematopoietic stem cell transplantation. In the classic example, we think about education. We think about it as relative to students, our residents, and our fellows. I mean, this is where we're teaching students to understand about this. But education also is extremely important to healthcare professionals. I'm constantly having to update myself in regard to what is the latest and greatest in terms of my field. I'm having to make sure that our nursing staff is well educated, that the pharmacists are well educated. We're always undergoing a continuous education process. Something happened here. So we also have to have education for our referring oncologists and their staffs, because when a patient goes back to the care of their primary oncologist physicians, that they know what's going on. And then finally, the most important, what I think is education of patients, their families, and their caregivers, because actually I believe this is an important factor in terms of the outcome of the patient after the transplantation. That's really going to be the focus of the remainder of my talk. And why is this important? So I was actually very afraid when I heard your talk was less is more, because I've actually been accused. I go, Dr. I usually spend an hour and a half to 2 hours with every new patient I see in consultation for bone marrow transplant. I go, wow, that was way too much. And I thought the focus was going to be less is more. And the reason being, so if we look at, this is just a general article on patients' memory for medical information, that 40 to 80% of medical information provided by healthcare practitioners is forgotten immediately after a visit, all right? So that's one thing. Next, the greater the amount of information presented, the lower of proportion is correctly recalled. And finally, this is what really scared me in reading this data. Almost half the information that is remembered is incorrect. So think about me in my verbose way of 2.5 hours, and I'm explaining the difference between a T cell and a B cell and an NK cell and an immunology, given they're basically coming out with better immunology, hopefully, than most of our residents, and after knowing this data. So it caused me, and so have people really looked, and I think about how that's applied just general medicine. So what about to bone marrow transplantation? And actually this was a lovely article that was produced by Stephanie Lee, who's now at Memorial Sloan Kettering, who's focused a large degree on patient education. And this is looked at the discrepancies between patient and physician estimates for the success of stem cell transplantation. And this article was in JAMA in 2001. And if you look at this is the type of transplant, there's two different types, autologous and allogeneic, and this is we're looking at this was what chance that perception of what was the perception of cure without a transplantation and cure with stem cell transplantation by physicians and patients. And so I'm just going to highlight a little bit about this. So if one looked at what was the physician thought they were telling the patient, you can see that it's about 7 to 8% for going through this in terms if they didn't have a transplant, and then what the patient thought they would receive in terms of if they didn't have a transplant. And then if we take it to look specifically at care, if the cure with a stem cell transplant, the estimates, again, are better, the physician, but look, it's nearly double what the patient expectation when they went after having the consultation of what was the physician laid to the patient, what the patient took away from it. And then if we look at, well, what is the reality of the situation? And this is the actual percentage of cures. And so the physicians tend to be a little bit on the conservative side and a little higher expectation among patients. So you can just see, this is just after initial consultation. So there is this necessity of what we're sharing and what we have to make sure that what we're relaying to patients. So these are the things, a little bit of the efforts that I've tried to do in the last year in terms of trying to improve education in hematopoietic stem cell transplantation. So we've done a complete assessment of all of our standard operating procedures for educational materials in the hematopoietic stem cell transplantation program. We looked at every way that who is delivering it, what is being delivered, and all of our materials. We actually did a review and complete revision of education materials, which I'm going to highlight for you in just a second. We actually had a formation of a multidisciplinary BMT education committee, and this education committee meets once a month. It's a multidisciplinary. It involves pharmacists, it involves nursing, it involves the physicians, and of our support staff and social work. And finally, we've hired a transplant coordinator who actually oversees all of these events, and this person makes sure that every one of the components within the educational process is being implemented and actually doing measurements, and we're doing this as a quality initiative in order to and looking at outcomes, which I'll actually share with you at the end of this. So this is our educational material. So we actually have 2 different books, and it now highlights our new beautiful hospital here, which we're into today. And you can just see some of the content relative to all of the portions of the transplant process, including patient resources and even down to parking. But what was more important relative to communication, we actually had this reviewed by the medical school has a communications department, and actually had this, well, we think what we're communicating is easy to read, but we've actually had somebody completely take every single page of this document to ensure that it's understood. And so by doing this, and actually it's brought down to a 4th grade level, so we're ensuring that every single person there is able to understand this wealth of information that's provided to every patient. So the second thing we did was we actually have had a Kaizen event, and I don't know if anybody is into lean management. I'm a big believer in lean management. Lean is what was implemented shortly after World War II in Japan, and Toyota is really known for this. And Kaizen, the Japanese word, it means good change. But what Kaizen means in terms of lean management is continuous improvement. And so you actually break down everything bit by bit. And we had a Kaizen event here just 2 weeks ago based upon education, where actually all of these people who you see in this group are actually pulled away from work and locked in a room for a week. And the idea was to break down every single bit of educational process of having a bone marrow transplantation. And just to give you an example, this is what they do. They get on the day and they map the points where education material should be improved, identify materials lacking, and identify who that should be. And it says where no material process, in yellow is material needs work. Look at all the red dots. And so this was actually, so we broke down our process so where we know, trying to take this. And it came away with these major ideas where it would result in improved safety, improved quality, and actually for the hospital would actually have a financial benefit. But the most important aspect of this, consistent, standard, evidence-based patient education will lead to decreased readmission rates and decreased morbidity and mortality. Again, showing where education plays a vital role in improving our patients' outcomes. So, and finally this, where are we going in terms of research? So I have the privilege of working with Ms. Jean Ridgway. She is a nurse practitioner with a master's degree who works within the bone marrow transplantation program, and Jean is in the process of getting her PhD through Villanova. And as part of this, she's going, I need a research project to get my PhD. And I go, well, I think I have a relatively good idea for you. And it's educational checklist for allogeneic stem cell transplantation patients. And so the purpose is to develop and evaluate a use of comprehensive educational checklist that will be used for our patients, that will be used by all members of our multidisciplinary team. It will streamline education for patients. It will decrease informational inconsistencies, decrease medication errors, and increase medication adherence, and improve communication between patients, families, and providers, including our referring physicians, and overall improve the efficiency and quality of our clinic visits. And so Jean was actually, this has written a specific protocol. It's actually going to go through our scientific review committee, and actually we're going to implement this within the year. So that's just a summary of the things that are going on for how I was saying that how my practice is in concert with the Bucksbaum Institute. If anybody's ever gone into my office, I'm a person who puts posters on every single aspect of the door. But the one thing that I have that I just keep, and this is what goes out before I go out my door every day, is I got to remember the core values. And the core values for me are clinical care, research, communication, education, and all of them important, and all of those are intertwined. So thank you very much.
Dr. Dirschl recently came to the University of Chicago to become the head of the new Department of Orthopaedics and Rehabilitative Medicine. Dr. Dirschl has served on many editorial boards and has served recently as president of the American Orthopaedic Association. Today, Dr. Dirschl, who's one of this year's new master clinicians, will speak on the topic Bone Health and Fragility Fractures, the Role of Patient Communication. Doug.
Thanks, Mark. Thank you so much. Thank you very much, Mark. It is truly an honor to be here today, and an even greater honor to be affiliated with the Bucksbaum Institute, what it stands for, and all the work it's doing. But I must admit that being an orthopedic surgeon in this kind of group makes me feel a bit under the microscope, because I feel I'm compelled to convince you that orthopedists actually do speak to their patients. We may use very small words and talk kind of slow, but we will talk to our patients, I promise you. I promise you. It's also really a pleasure for me to present to you today just a little bit of information this afternoon about a local stratagem we're beginning to employ in the context of a lot broader work I'm engaged with on a major national health issue. Fragility fractures are defined as any low-energy fracture in someone over 50 years of age by the National Osteoporosis Foundation and by a bunch of other groups, and that's any fracture. And the reason is that these fractures are harbingers of bone health problems, poor bone mass, osteopenia, and osteoporosis. And they're epidemic in the United States. Over 2 million of these occur each year. Couple ways to put that in context. One is that's more than 10 times the number of new breast cancer cases each year, more than 7 times the number of heart attacks each year. Another way to put it in context is that women over 50 in this country, 1 in 2 of them, over 50%. See, that's the orthopedic thing. 1 in 2 is over 50%, right? I thought I'd slip that in and see if you got it. 50% of women over 50 will sustain at least one of these fractures in her lifetime. This is a huge public health issue for us in this country. And while my profession, the orthopedic surgeon, feels they do a reasonably good job of caring for the fractures in all these patients, we, my profession, and the whole healthcare system do an abysmal job of caring for their bone disease beyond the fracture. National data shows us that only 1 in 5 of these patients with a fragility fracture get any sort of evaluation or, if necessary, treatment for their bone after the injury. Now, compare this to beta blockers after heart attack, another secondary prevention measure. You're trying to prevent the second heart attack, just as we're trying to prevent the second fracture. Much better performance. And primary prevention measures, such as colorectal cancer screening or mammography, much, much higher performance. This is really bad and something we need to work at. Well, why does this happen? Well, patients are in denial about this. There's no question. I hear it all the time because I treat fractures. Dr. Dirschl, you have no idea. If only you'd been there, you would have seen what kind of a fall I took, and anyone would have broken their bone from that fall. Maybe, but it's still likely to be related to poor bone mass. But in addition to patients being in denial about it, physicians, providers, very busy healthcare practitioners give them that out. We either overlook the bone disease as associated with a fracture, we ignore it, or since I'm an optimist, I prefer to think we all recognize it, but we're just so busy and have other priorities that we don't take the time to talk to our patients about it. Because we know that if we do some things, some simple things, we can reduce the incidence of future fractures. So what happens where this all intersects is in something I call the fragility fracture cycle. The patient starts at the top of this curve with already poor bone mass. They sustain a fracture, get it treated, rehab from the fracture, and then they get to that box or circle with the question marks. And that's where, if anybody was going to do something to evaluate and potentially treat their bone disease, they would. But it doesn't happen because we overlook it, because we ignore it. And then the patient feeds back to the top of that cycle. Now their bone mass has gone from yellow to orange to red, much lower than it was when they started, because we have good scientific evidence to show that women in the year after a hip fracture lose bone at a rate 5 times that of the normal postmenopausal rate. It's a physiologic effect of the insult of the fracture and surgery. And they feed to the top of the cycle, and that's why there's a 6 to 12 times greater incidence of the second fracture after you've had the first. So we want to engage with this group of patients nationally as well as locally in the concept of secondary prevention. Identify those people because they've had the first fracture. Use that as a moment in their life, a moment in their care, to convince them that doing something makes a difference, and then make it happen. And we do this. The problem is we've done it very poorly. We just published this data from national claims data looking at the rate of treatment of patients after a fragility fracture over the past decade. And these different lines are the various anatomical locations of fractures. It's not important that you know which is which, although some get treated at a higher rate than others. But the trend here is consistent throughout. Treatment rates have gone down over the past 10 to 12 years. This is in spite of national effort to raise awareness. This is in spite of new drugs being on the market in greater volume that are easier to take. This is in spite of JAMA coming out with things, Joint Commission standards, CMS PQRI measures. This has gone down because of one of two or a combination of two things. Fear, which is out there in patients' minds about taking any of these bone-active medications, and how busy doctors have gotten. Imagine how the life is different for a primary care physician 10 years ago as it is now. More priorities, more guidelines, more things to think about, higher pressures, as we were shown, to see more patients. We're just not getting this done. So we know this works, but the question is, how do we make it happen? And so what we've embraced, which is what I'm working on nationally, is something called a fracture liaison service, where when we identify this patient with a fracture, we intervene and ideally send the patient down a different pathway instead of around that cycle, where we get involved, we evaluate their bone mass, we get a history, we educate them, and hopefully we treat those that need to be treated, and then they have improved bone mass and better functional outcomes. But it's hard to do. It's hard to get there because first we have to identify those patients. Who are they? And then we have to do something about it and intervene. And the doing something requires coordination of care. And the area we really are focused on, and what I'm sharing with you this afternoon, is that moment in the patient's life when they're in the doctor's office, in the emergency department, in the hospital with their fracture. That's what we call a teachable moment. And I think my profession, orthopedic surgeons, are not doing what we ought to do if we don't take advantage of that moment and speak directly to the patient, look them in the eye, and tell them there's a bigger problem here than just your broken wrist. And that's what we're trying to do here. And we're doing it by engaging our entire orthopedic group, including the residents, because I think it's good modeling for them, and we hope it'll translate into a practice pattern for them in identifying these people and in intervening. So in our department, every patient with a fracture over 50 should get this speech that I'll show you in a minute, should get this evaluation. We've given a script to all of our residents that we laminated and they're supposed to have in their pockets. And when a patient comes, and that tells them exactly what to do for every patient that comes in with a fracture over 50. After that, we then follow up with some of our nurse practitioners to try to get the patient in for evaluation and care. And here's the script. I'm not going to read it to you. It's in small orthopedic words, of course. But basically, it says, you have a fracture, but that's only the tip of the iceberg. You should really take this seriously, do something about it. Our team will contact you, and we'll do something else. We'll work on this. And we've been doing this now for a little while. I'll just give you the early results and then take questions. We officially kick this off February 1st, although we've been working on it for a while and doing a little bit of other things. When the residents see one of these patients, they just drop them into a separate patient list we created on Epic called the Bone Health List. And we're now adding patients to that list at a rate of about 15 per week. That's the rate at which we're seeing these fractures just in our area here. Everybody, the residents report anyway. We haven't surveyed patients yet, but residents report everyone's getting the script, everyone's getting the speech. And now of those patients, we've been able to go back through that list and contact through our bone health clinic. 40% have agreed to come in for a bone health clinic visit. That's about 10 to 15 percentage points higher than what's been reported in the literature for most studies that have been shown. So maybe, at least in early returns, we're doing better. And another 23% have said, I'm really not going to come in to see you, but I guarantee you my primary care doc is engaged in this and we're working on it. We have yet to survey the primary care docs as well, but we will close that loop as well and really see. Because if 63% of these patients are starting down the evaluation pathway, that would be a big step forward. And I think the key factor will be because an orthopedist took the time to talk to the patient and tell them something more than we just need to treat your fracture. And so far, the residents have loved it. The script gives them something they can do and say to patients. They don't have to make it up themselves. And it's a reminder. I also give them reminders every morning at conference when they show a fracture in a patient over 50 that we need to be doing this. So I appreciate your attention. Again, just a small snippet of something we're trying to do locally, but I'd be happy to answer any questions.
You script other things for the residents? It was a question that came up this morning in our board meeting about the use of scripts to improve.
Yeah, we're not currently scripting other things. There are things I'd love to script, and I loved your presentation, and that's the core of it. I ask every morning, why did you get this CT scan? Interesting, our residents have figured this out, so their answer is always, I didn't order it, the ED did. But I'd really like to script, I'd like to script more of this. But I think in some specific patient communication situations, it makes great sense. I worry if we script everything for them, that then they won't, rather than gaining the ability to communicate, they're simply going to gain the ability to read something. Yeah. All right, thank you.
Our next speaker will be a master clinician recently appointed to the Bucksbaum Institute, Dr. Jessica Kandel. Dr. Kandel came to the university recently from Columbia University in New York as the head of pediatric surgery and is an expert on the treatment of pediatric cancers. Dr. Kandel's research has focused on the development and differentiation of blood vessels, angiogenesis, in solid tumors, and vascular anomalies. Today, Dr. Kandel will speak on the topic, Biologically Targeted Therapy for Children with Vascular Anomalies, Conversations with Families about how to use new information. Dr. Kandel.
How do I go forward? Thank you very much. So I'm going to be speaking about a set of conditions that are almost polar opposites from orthopedic fractures in adults or stroke or heart disease, also in adults. Vascular anomalies in childhood are very poorly understood and were really only recognized as a set of related conditions within the last 50 years. Almost all the tools with which we've had to treat these children have been empiric. And I'm going to disclose that I'm going to talk about the use of propranolol for vascular anomalies. I'm very comfortable doing that because essentially all the medications that we use in the Children's Hospital were not FDA approved for use in pediatrics. So propranolol just joins that group. All the patient photographs that I'm going to show you were obtained and are shown by consent. So what are vascular anomalies? They're congenital errors in the development of the vascular system. They can involve arteries, veins, or lymphatic, and the effects are really protean. They can be nothing, as in the case of the most common form of vascular anomaly, which is a hemangioma. About 10% of normal babies have hemangiomas, and they just go away by themselves. They have no effect on the children. But the outliers can have very significant effects. They can cause circulatory overload with congestive heart failure. There can be stasis and edema. There can be mass effects on the involved organs, which are very significant. And there can be a very significant predisposition to infection. Among the group of these children that are severely affected are those with cervicofacial lymphatic anomalies. These are increasingly observed on antenatal studies, including studies of fetuses that did not survive to term. And they raise questions of airway management during delivery. And this only happens for a couple of reasons. One, that we now have the technology to evaluate whether babies' tracheas are open before they're born. With an ultrasound test, we can see fluid moving up and down the trachea, and so we can know whether children are at risk for asphyxiation. The second thing is that we have developed a very high-tech, high-potential morbidity procedure called an exit procedure, which is an ex utero intrapartum treatment procedure, which really means that we deliver the baby still attached to the placenta by cesarean section, having profoundly anesthetized the mother, so that the baby can continue to be supported on the placental circulation while an airway or perfusion are established. This is obviously a pretty significant undertaking. And this is a picture of a little baby who has a significant lymphatic anomaly. So these white bubbles in the baby's chin area are not supposed to be there. They extend all the way into the baby's thorax and almost completely obstruct the airway. It used to be that having seen this, the kind of conversation we had with families was pretty alarming. We talked to them about things like exit procedures, which carry a very heavy sense of compulsion for the family. Obviously, they don't want to have their baby harmed, but it's a pretty significant undertaking to have a baby delivered when the mother has to be anesthetized and have a kind of cesarean section that will compel her to have continuing cesarean sections with further pregnancies. So these are really non-trivial. This is another child who is at risk for stasis and infection. These are MRI cuts. And you may not be used to seeing MRIs, but you can see this tissue that looks like a sponge. And it's really all over this little boy's body. And by the time he was 7, he had had multiple procedures to treat infection and stasis in these tissues. We had very little to offer this family. There are no preventive therapies. There were no medical therapies. And because this tissue is intimately interwoven with his body, there was no surgical cure. These are really tough conversations to have with families. So we, as physicians practicing in an academic medical center, had a unique set of potential tools. And one of the things that we decided we needed to do was to ask, can we determine the biological origin of these anomalies to develop better therapies for children? So, So one of the things we did was simply to bank tissues from children who had undergone surgical procedures and to try and determine whether there were cell types in the tissues that had the possibility, the potential to proliferate further, not like cancers, but the way that tissues develop during infancy. So we were looking for cells that were progenitor cells or stem cells. And in this slide, we're using the green stain to look for normal lymphatic vessels, and you can see they're very thin and delicate. In this slide, we're looking at a lymphatic malformation, what we call an LM, and we're using a special stain in red to look for something called CD133, and that's a marker for stem cells. And these stem cells should not still be here. This is a child who has been born and who has grown and had an operation for the lymphatic malformation. Here's another one, and there's stem cells everywhere. So it suggests that development of these children in these involved tissues has gone down a wrong path, and this gave us a very important clue. We tried to see if we could link these new mechanisms to potentially targetable pathways. So what we did was isolate these stem cells using that CD133 marker, and then we tested them against a whole range of drugs that we thought might be safe for children and might affect the growth of these stem cells. And in this slide, you can see that these lymphatic malformation progenitor stem cells were exquisitely sensitive to a very old drug called propranolol. And that was a very nice finding for us. I think anybody who's worried about cost would be very happy to see that a new treatment involved an old generic drug that has been used safely in children for 40 years. So we were very excited about that. The last thing we wanted to do was to ask whether we could build a model that would allow us to test these targeted therapies before we turn them loose on children. So we took the cells that we had isolated and we put them in mice, and we did ultrasounds on the mice to see if they looked like the lymphatic malformations we saw in children. And this is a chunk of the surrounding gel that we implant the tissues in, and really nothing has happened here. It's very featureless. Over here, there are all sorts of little circles, and they're a bit reminiscent of the first MR study that I showed you, and this is in fact a lymphatic malformation recapitulated in a mouse. So now, our conversation with families changed. We had new information that we had developed ourselves in the laboratory, and very fortunately, the new information hinged on a drug that we felt very comfortable using in children. So we spoke to this family. We explained to them how we had developed this information and why we thought it might be useful for their child. And this family was pretty gun-shy after many years in the medical system. So we decided that we would try to treat the cutaneous portion of this child's anomaly using an ophthalmic gel that contains a relative of propranolol called timolol. And we gave the gel to his mother, and she had been his primary caregiver for many years. And she reported to us that the cutaneous portion of his lymphatic malformation healed with topical timolol. And the parents began to trust that this might be a path forward. So the patient was begun on oral propranolol at a standard dose for children. The parents reported to us by telephone that his lesion was shrinking and that his eruptions were healing. And 2 weeks later, he was out of the wheelchair. So this was a truly extraordinary finding. I have to say, I think it should probably never happen to a basic researcher because you shouldn't ever hope that you can go from isolated cells to mice to people and have this kind of result. But it was very gratifying and obviously has completely changed the experience of illness for this children and for this child. And his result has persisted for 2.5 years. This was another conversation that we had after the identification of propranolol as a potential treatment for lymphatic malformations. Another very fortunate thing about this particular drug is that it has been used in pregnancy for many years to treat fetal supraventricular tachycardia. So our maternal fetal medicine colleagues are also comfortable with it. This is a mother who was found at 33 weeks, pretty early in gestation, and her baby has those little bubbles surrounding the trachea that have lymphatic malformation in them, and we found that there was no movement of fluid in the tracheal, what would be the tracheal air column after birth. So we were quite concerned that the baby was at risk for asphyxia. So the parents were offered a number of options, one of which was no medical therapy but exit support at birth, and the other was propranolol to start during pregnancy. And they elected to start propranolol. And again, very gratifying. The lesions stayed the same size, but babies grow quite a lot between 33 and 38 weeks. So the baby grew, the lesion didn't, and the baby was born breathing spontaneously with APGARs of 9 and 9 and has continued to do well. So this is another very gratifying result. I think in summary, lymphatic anomalies patients and vascular anomalies patients really benefit from a multidisciplinary and translational approach. And we've begun to be able to talk to families about this. Our increasing biologic understanding has revealed new targets for treatment. And our discussions with families have expanded to include those. And it's allowed us to really rapidly bring new treatment options to these patients. Thank you very much.
Question? Dr.
What's
Rubenstein.
the pharmacological role that propranolol plays molecularly to do the things that it does?
So we have found that the lymphatic progenitor cells express all 3 beta-adrenergic receptors. Beta-adrenergic receptors are upstream from a number of angiogenic modulators. They positively regulate vascular endothelial growth factor. So that is certainly one potential pathway that's being affected, but there are probably others.
Other questions? As someone who used propranolol in the old days for about 15 years for coronary artery disease, when it was only approved on label in the U.S. as an antihypertensive, I'm very sensitive to the idea that off-label use often has great benefits. Thank you very much. Our next speaker will be Dr. Ross Milner. Dr. Milner was the first master clinician in the Bucksbaum Institute in 2012. Dr. Milner came to the university from Loyola Medical Center in Chicago, where he was chief of vascular surgery, joined our vascular program as the head of the aortic disease program, and has gotten increasingly involved through the Bucksbaum Institute in undergraduate pre-medical education. Today, Ross will talk about UCHIP Clinical Excellence Scholar Program. Ross, welcome.
Thank you, Mark. And thank you, everybody. I apologize for the attire, as one of my roles, as Mark said, as director of the aortic program. I got direct doctor-patient relationship at about 2 o'clock in the morning with a ruptured aneurysm. So this is my disclosure for clothing, and I apologize. So I have no conflicts with this. I wanted to thank the Bucksbaums, as many people have, for doing this, and I wanted to thank Mark for his really strong continued support of the surgical specialties. Just 3 surgeons up here as master clinicians. It's probably pretty unusual, I would think, and I think that really is Mark's commitment to supporting surgeons as well for what we do from a clinical excellence standpoint. I'm going to try to talk about something a little bit different, if I can get my slides to advance. Not in terms of direct doctor-patient relationship, but how can the Bucksbaum Institute and what we can do as faculty members of the Bucksbaum Institute impact the next generation of physicians? And I think there's a huge role in learning to be a good physician if you learn early and learn from mentors in an early way. One of the questions I first asked when I got this appointment was, why me? And I got asked multiple times, what do you do? And I think I'm starting to figure out a little bit better now what it means to be a master clinician within the Bucksbaum Institute and what we can do in the Bucksbaum Institute outside of just direct doctor-patient relationships. So I put this up here. This is taken from encyclopedia.com. I apologize for where I took it from, but it was easy to cut and paste into a slide. What a mentor is. And I think when you look at line 1, a wise and trusted counselor or teacher, clearly all of us have mentors. Clearly we enjoy being mentors for other people. And I think one of the responsibilities of being an academic physician is to be a mentor to others. I'm putting this up here for a reason because my mentors had a lot to do with where I am today. You'll see some redundancy in this theme here in a second. But I went to the University of Pennsylvania for undergraduate school, went there for the medical school, trained there for general surgery, and then, believe it or not, I actually stayed there to do my fellowship as well. So 16 years at the same institution. Some people are concerned when you train at the same place because you don't learn new techniques, you don't learn different things, you get the same bad ideas and make the same bad decisions about what tests you should be getting because you're getting trained by all the same people all the time. But you also develop some pretty unique relationships when you have an opportunity to be someplace for that period of time. So 16 years at one place means a slide like this. And this is what I was telling you last night when we spoke, because I know you would appreciate this. This slide took about 5 minutes to make probably, but the significance of the people on the slide and the significance this has to me is unbelievable in how it got me to where I am in my career right now. These 5 surgeons were truly master clinicians in my mind and had an unbelievable impact on my career and continue for some of them to have an impact on many careers. And one of the unique parts of this slide is my old chairman of surgery, Dr. Barker, and my old chief of vascular surgery, Ron Fairman. They are mentor and mentee and are mentors for me. I also had the opportunity to go abroad when I finished my training, and I went to Utrecht. And for any of the younger people in the audience, studying abroad is an unbelievable opportunity, and the mentorship and professionalism you can gain from that and getting an opportunity to see other places is remarkable. And this is another one of my mentors. Jan is now become a great friend, but continues to be a mentor and someone that I really enjoy his relationship. And it's funny, as you get to different points in your life and interact with different people, and now as I interact with the undergrads, I just was on family vacation in Amsterdam, and I worked with Jan when I was in Holland, and he came and joined my family for dinner and sent me an email afterwards saying, "I'm very proud of you," which is sort of funny to hear at this point in my career. But at the same time, you realize what a great mentor he is, that he took the time to write a one-line email to me about what I've been doing, and it's very nice. So again, mentorship, where is this relevant? So, it's relevant to our undergraduate population here at the university. I think as faculty members, we do a tremendous amount with the medical school, and we have a really unique opportunity to provide unbelievable educational experiences for undergraduate students as well. Get them involved, teach them what it means to be involved in a good doctor-patient relationship, and to learn what it's like to have mentors and then be mentors yourself. I'm sharing this with you because at the time I presented this last year, this was slightly a pipe dream, and it's now come into a very positive light for the undergraduate school, and I'll share with you the status of where we're at. So this we called at the time the University of Chicago Clinical Excellence Track Initiative. It was going to be a collaboration between the undergraduate school. Joni Krapek and Melissa Paddock have done an unbelievable job from the college. The Bucksbaum Institute under Mark's, obviously, leadership, but Angela and I have had an opportunity to work very closely together on this, and I've learned a lot from Angela about this in the University of Chicago School of Medicine, Pritzker School of Medicine. So the college was going to help with student recruitment, event planning, trying to measure and define the program success, and then the Bucksbaum Institute's role was going to be pretty significant. The On Being a Doctor series, which at the time, and I left this way because I think it's very appropriate, was going to be coordinated by Dr. Schwab. And as many of you know, Dr. Schwab, who had an unbelievable influence on this institution, passed away this past year. But in his honor, this On Being a Doctor series has now been named for him. Many of the people in this room have spoken in that, and many will probably get invitations to speak on that in the future. But what Dr. Schwab did for mentorship and shadowing can't really be matched. I'm trying to mimic a little bit what he did, but he's big shoes to fill. get students to come to the Bucksbaum Institute public lectures. I'm going to embarrass a couple of my students, but can you guys raise your hands that are here? So we have people, there you go, raise them high. So people that are here, and there's a couple that are outside as well, that are involved with the Clinical Excellence Program, have quarterly events, support development of a course within the college, which John, who's back in the room, I'm going to embarrass him now, has done an amazing job with this. And in fact, I was honored recently just to speak in his course, and it was a great experience. The amount of enthusiasm in that room and interest from the students is unbelievable, and congratulations on what you've done with that, John. It's outstanding. What are the students responsible for doing? They need to volunteer and shadow for 100 hours of service. So it's a pretty significant requirement. What we've asked them to do is do something unique. So when they graduate, on their transcript, they'll have an additional distinction that says they are a clinical excellence scholar. And there's a fair bit of work that needs to be done to do that. They need to come to the On Being a Doctor lecture series, be involved with the shadowing program, have mentorship, and the whole part of the project, everything together will work to get you this experience. So since last year when I presented this, we selected our first group of scholars that was done as a collaboration between Bucksbaum and between the undergraduate school. We had a significant number of applications, and it was a challenge to get down to 24. We currently are meeting bi-monthly for dinners, which has been fun for me because I get to go over to the undergraduate school. And if any of you have any Penn affiliation, the undergraduate campus actually looks like Penn a little bit. And I walk into Ida Noyes Hall and whatnot. I think I'm back in Houston Hall. It takes me back to my undergraduate days. But we meet bi-monthly. We talk about their experiences, share their shadowing experiences, and discuss a lot what they look at as what's good and bad in terms of doctor-patient relationship. And there's a real value to the students getting a chance to share their experiences. It's been really valuable. And as well, some of what we just discussed is just specifics about the program. One of the things which I think is fantastic, and again shows the attitude of Bucksbaum and the collaboration with the undergraduate school, all of our scholars have been paired with a Bucksbaum scholar for shadowing. So thank you to those of you in the room who have given your time to do that. It is much appreciated. The students love it, and thank you for you guys for doing that. Many of the Bucksbaum scholars have lectured to the students in different capacities and part of the On Being a Doctor series and in John's course. And one of the parts of this, which I didn't really anticipate when we started, I now just in the past couple weeks have 3 students that I was able to get summer research opportunities they weren't able to get otherwise because of some of the relationships that I have with people in the medical school when they were struggling to get sort of the appropriate exposure for research. So I think that's really spectacular as well. The next class has submitted their applications, and I don't know, Angela walked out, but we now have the next duty of selecting the next 24. So they get applications go in as freshmen. They get, first years. I apologize. I know that's wrong. I'm learning. So as first years, they will start the program as second years, and it continues through their the remaining 3 years of their undergraduate school. So the next class has submitted their applications. So there was so much enthusiasm about this through the undergraduate school that a bunch of the 3rd and 4th year students came to Joni and Melissa and her team and said, we want these experiences as well. How do we get them? So Joni and Melissa came to me and said, look, we need probably to get shadows for 30 or 40 students, and it seemed like a relatively monumental task to accomplish. And through Mark's support and through Dean Polonsky's support, we sent out an email to the faculty, and we had almost 100 faculty members outside of Bucksbaum, almost 100 faculty members say they were willing to have undergraduate students shadow them. Pretty amazing. So there really wasn't a formalized shadowing program. Dr. Schwab had done a lot of this in an informal way, and so this has formalized this. A lot of support from Mark and from Dr. Polonsky, and as I said, almost 100 faculty members. This is in place. It's been very successful so far, and the students have really loved it. This is a recent email that I got from one of the students. Thank you so much for your help with this and for the time, which this was summer research, and for the time you put into the Clinical Excellence Program. It is greatly appreciated. This is mentorship, right? Now, it's fun for me when I get an email from my old mentor saying I'm proud of what you do, but it's even more fun for me to get an email like this from one of the students saying, thanks for taking the time. So Mark, Matt, Angela, thank you for allowing this to be part of the Bucksbaum Institute. I think it's amazing what it's going to do and continue to do for the undergraduate school and for people who want to become physicians one day to get the right role models and learn. And obviously, Mrs. Bucksbaum, Kay, thank you for everything that you've done to support this.
Questions for us? John, have the students been fun to teach? The course has gone well. How many of those students have signed up for the 100 people ready to shadow?
So there was 36, I want to say, that wanted to shadow, and all of them now have shadows and have started to shadow. And the response back has been unbelievably positive because, as you can imagine, for students when they don't know exactly where to look or where to go, it's sometimes a little bit of a challenge. And now that it's been centralized like this, it's easy and it's worked very, very well. Sorry.
I just wondered whether there's any negative feedback or any feedback at all from patients who have shadowing undergraduate students in their clinical encounter?
So I have not heard of any personally. I've had some students shadow with me. I actually think patients like the attention and feeling like they're part of someone's education. And I always present it in the same way. I say, it's undergraduate student who's interested in becoming a physician one day, who's here to learn. And I've never had a single patient look at me and say either don't have them in the room or I've not heard a negative experience back from that. Now, maybe patients are uncomfortable speaking up in that environment, but overwhelmingly, most people, when you say this is a student who's here to learn and wants to become a physician one day, people are very supportive of that.
That's from my experience.
So we tried very hard when we were getting this program introduced to both our clinical excellence scholars and to the other students who are shadowing now through third and fourth year, to meet with them ahead of time, to explain to them exactly how this was going to work and what their role might look like on the team, which in some respects almost feels like standing in the corner sometimes, I realize. So we made sure that they understood how the teamwork, how the attendings are, the residents, fellows, and whatnot, and medical students, who else would potentially be around, and they understand that hierarchy pretty well. And I think because of that, they've been very respectful of the medical teams and the attending physicians that are involved in the care. And so far, I've not heard any negative feedback with that as well. But I think part of it is we did a lot of education ahead of time to make sure that the students had an appropriate expectation of what their shadowing experiences would be like.
Tipu.
So, not particularly, but I will tell you we were very conscientious when we went through the selection process specifically for the clinical excellence scholars to make sure that we were careful to have a diverse group of people involved. So we haven't specifically sought out underrepresented minorities or minority groups within the undergraduate school to do this, but when we selected our first group of scholars, it's a very diverse group of students. Great. Thank you very much.
Thanks, Ken.